Hello, thank you very much for joining us in this seminar about Reoxcare. I'm Begoña Castro, Scientific Director of Histosa, the company that has developed Reoxcare. I am very delighted to present you about our technology. We are going to talk about Reoxcare and how we are going to provide a natural defense to promote wound healing. First, just a few words to tell you that Histocell is a biopharmaceutical company for the development of new products in regenerative medicine. We are located at Bilbao in the Basque Country in the north of Spain, and we have our R&D laboratories for new products development and 2 manufacturing plants, one of them dedicated only to cell therapy medicaments production, where we work with the stem cells, and the other for medical device manufacturing, as it is the case of Reoxcare. Reoxcare is an antioxidant treatment that promotes the natural wound healing process, and our contribution to wound healing process is focused in the release of the excess of free radicals that are in the wound's environment and are delaying the healing progression. There is a delicate balance in biological systems between the amount of oxidant and antioxidant compounds to prevent the damage of cells. Cells in healthy conditions and patients in healthy conditions have the ability to maintain these equilibriums, this balance in redox homeostasis. But when these defense systems fails, when the patients have a very important comorbidities, there is a disruption of this balance that results in a pathologic condition that is the oxidative stress. Disease like diabetes, ischemia, venous disease, obesity, bad lifestyle habits, or AIDS, common disease that we usually can see in our patients with complex wounds, produce an excess of free radicals and then this pathologic oxidative stress situation that produce a chronic inflammation situation, a decrease in the antioxidant defenses, a lower repair capacity, and in addition, a less responsiveness to the therapies that we are applying in these wounds. If we compare what happens in acute and chronic wounds or in healing versus non-healing wounds, we can understand very well the difference. In case of an acute wounds, there is an increase in the level of free radicals because they are important molecules implicated in bacterial elimination and also as signaling molecules that regulate intracellular pathways related with healing process. But when their role has finished, the antioxidant defenses perform a gradual detoxification and returns to the situation of this equilibrium redox, this homeostasis redox, maintaining the control over inflammation. But in case of chronic wounds, the situation is totally different. This detoxification process does not work due to the uncontrolled and persistent production of free radicals during the inflammatory phase. And although the antioxidant response increases, it is not able to neutralize the radicals. There is an arrest in the wound healing process, in the inflammatory phase of wound healing process, and there is no spontaneous tendency to the formation of the granulation tissue. This way, the necessary physiological inflammation turns in this way to a pathological inflammation that extremely difficults the wound healing process. The presence of oxidative stress in chronic wounds has been demonstrated by several authors. In this case, oxidative stress has been measured in acute and chronic wound exudates through uric acid allantoin ratio, because in presence of oxidative stress, uric acid is converted to allantoin, and we can measure it. So it can be observed that exudates from chronic wounds present a significant higher oxidative stress level with respect to acute wounds exudates, and non-responding chronic wounds present even more of this ratio with respect to responding ones. We can also observe directly the presence of these free radicals in the wound tissue, in this case in a venous wound, through a specific Prussian blue staining implicated in Fenton reaction, in which free radicals are generated. Free radicals produce in the wound's environment the inhibition of migration and proliferation of keratinocytes, the induction of the senescence of the fibroblasts, that is the main cells implicated in the proliferative tissue, in the granulation tissue. They produce also the direct damage of important cell structures like nucleic acids, lipids, and proteins. It produces also the inactivation of proteasase inhibitors that produce finally the increase of matrix metalloproteases level in the wound environment also. And it produces also the depletion or the decrease in the activity of the physiological antioxidants defense. And in this adverse situation, the objective of Reoxcare is to neutralize the excess of free radicals in the wound environment, to detoxify them, and to move from an oxidative stress situation, a pro-inflammatory environment, through an equilibrium, an oxidative balance, to overcome the inflammatory phase. For this purpose, we have taken advantage of natural resources to develop Reoxcare, and this tree is very important for us. It's carrot tree that is typical from Mediterranean basin, Mediterranean area, because from their seeds we obtain the main component of our product, the absorbent matrix. And the other component of Reoxcare is an antioxidant solution that also contains curcumin and N-acetylcysteine. Let's go to see the properties of each of the ingredients. We obtain the absorbent matrix from the flower of the seeds of carrot tree. The chemical structure is a galactomannan, a polymer, in this case of galactose and mannose, and it is well-known in natural and traditional medicine because it has been used for gastrointestinal disorders, inflammations, or to calm gastric ulcers, because this galactomannan decreases inflammation and damage from the oxidative stress situation due to its antioxidant activity. On the other hand, the antioxidant solution contains N-acetylcysteine because it has a very potent antioxidant activity and also very important in non-healing wounds. Different authors have described the role in N-acetylcysteine in the control of different types of bacteria that are present in wounds biofilm, and the curcumin, also present in the solution. As you probably know, curcumin has been used in traditional medicine due to all the important benefits, including in all phases of the wound healing process. Indeed, it has been shown that the use of curcumin in diabetic foot ulcers produces the decrease of pro-inflammatory proteins, a decrease also in matrix metalloproteases, an increase in physiological antioxidant defenses, and finally, we can obtain a better revitalization process. We have previously demonstrated the high antioxidant capacity of all Reoxcare components, the galactomannan matrix, the curcumin, and the N-acetylcysteine, and the capacity to protect the cells in oxidative environments. In these situations, Reoxcare increase human fibroblast viability and decrease the intracellular levels of free radicals. Also, we can see a decrease of pro-inflammatory mediators in the cells that it translates in patients, as we can see in our clinical trials, in a decrease of the level of pain in the wounds. And how Reoxcare works. The matrix absorbs the antioxidant solution and changes from a vegetal rigid matrix into a moist, flexible, and very easy to use matrix, and very, very well tolerated by the patients. This way, if we add all the solution in the matrix, only a 50% of the matrix is hydrated, and thus it can keep the capacity to absorb wound exudates. And the antioxidant solution and the matrix act synergistically to obtain a really very, very potent antioxidant activity and detoxification capacity over the wound's exudates. We apply Reoxcare in different type of wounds, like venom wounds, traumatic wounds, ischemic, diabetic foot ulcers, pressure ulcers, and burns in the inflammatory phase of all these type of wounds. We have here the differential activity from other dressings or from other technologies, because Reoxcare is directed specifically to the inflammatory phase of the wound healing process. The instructions of use are very easy. We can find in the box the matrix and the solution. It's a sterile and a single-use product. We open the blister, add the solution to the matrix, and wait around 1 minute until total matrix hydration. We recommend to adapt matrix to wound bed shape, if possible, and to apply directly to the wound bed. Then, as Reoxcare is a primary dressing, we need to cover with a secondary dressing to maintain Reoxcare and to manage the wound exudates. With the use of Reoxcare, we achieve the activation of the wound through different mechanisms. As we have commented, the potent antioxidant activity that neutralizes the excess of free radicals that have to overcome this inflammatory phase and produce also a very important pain relief in the wounds in the patients. We have also a nice debridement capacity in case of soft non-viable tissue. So we can apply Reoxcare in presence of soft non-viable tissue like sluggy tissue, fibrinous tissue, and so we don't need a clean wound to apply Reoxcare, like a clean wound bed to apply Reoxcare. We don't need it. But I would like to underline that we must follow, and it is important to follow the good clinical practice in wound healing regarding the elimination of the vitalized tissues as much as possible and perform a deep cleaning of the wound in each wound dressing chains. Reoxcare avoids biofilm interaction in the wound healing process. This conclusion is based on our clinical observations in our trials and in the clinical experiences in these years of experience with Reoxcare, but we are investigating which are the mechanisms of action of Reoxcare over the biofilm. So we are collaborating here in the University of Basque Country in a special group specialized in microbiology, and also with Dr. Schultz in the University of Florida, just to know which is directly the mechanism of action of Reoxcare in the biofilm regulation. We maintain a healthy wound bed and promote new granulation tissue formation, and we produce an appropriate wound management exudates when combined with a suitable secondary dressings. And it's a product that is very adaptable, easy to replace. It is doesn't adhere to the wound bed, and is very, very well tolerated by the clinicians and also by the patients. To see easily how Reoxcare function, we have here a non-healing wound or a complex wound with many inflammatory cells recruited that produce an excess of free radicals in this wound's environment. In this situation, we apply Reoxcare directly to the wound bed to eliminate the excess of free radicals. We prepare the wound bed and promote the formation of granulation tissue that finally will fill the wounds. Reoxcare also promotes wound edges activation, and at this moment, Reoxcare has achieved the main objective in the wounds, and we can change to other most wound healing dressings or technology, or if we have a special difficult, some clinicians also decide to leave Reoxcare until wound closure. We are going to see now some recommendations for Reoxcare use. Just to tell you, to underline that Reoxcare is indicated in the inflammatory phase of the wounds. And we are going to achieve wounds activation through the contribution to non-viable tissue, soft non-viable tissue elimination, granulation tissue formation, and wound edges activation. And to achieve these effects, we recommend to maintain Reoxcare treatment at least for 4 weeks in the wounds, 1 month of treatments. Reoxcare is not indicated for wounds that present local signs of infection. In this case, it is necessary to apply an antimicrobial specific strategy with antimicrobial dressing or systemic antibiotics, depending on a patient's needs. But when local signs of infection have solved, we recommend the use of Reoxcare to activate wound healing process. It is not indicated in case of presence of necrotic plaque, and in this case, it is better to eliminate with an appropriate debridement techniques and then to apply Reoxcare. And also, it is not indicated in patients with critical lymph ischemia without pulse or with an ankle fraction index below 0.6. As it is indicated to direct these patients to a vascular specialist to improve at least these ischemic conditions in order the wound have the enough irrigation just to respond to the treatments. As a general recommendation, Reoxcare must be changed every 3-4 days, twice a week, with the suitable secondary dressing adapted to the level of exudates that present the wounds. In this table, we can see a protocol that we normally follow about the use of the secondary dressing. If we have a highly exudative wounds after Reoxcare, we can apply alginates or nitro fiber, and then a foam with adhesive silicone and hydrocellular with adhesive silicone. It will have moderate exudative wounds. We need only this foam with adhesive border on a nitrocellular with adhesive border or without adhesive border. It depends in the type of skin that patients has. And if we have non-exudative or very poor exudative wounds, it is important to apply non-absorbing secondary dressings, yes, to avoid the drying of the vegetal matrix. And then we can apply a polyurethane foam or similar without any absorption capacity. If we need to complement the hydration of the matrix, the moist in the matrix, we can apply also physiological serum or an hydrogel above Reoxcare. And it is important also to protect perilesional skin with a barrier system, any barrier system that you prefer, and because to avoid the damage of the perilesional skin by exudates from the wound. Because if we are going to change each 3-4 days, twice a week, it is important, especially in highly or moderately exudative wounds, to avoid the damage of the perilesional skin by these exudates. We can say that Reoxcare avoids biofilm interference in the wound beds, that Reoxcare can be used with any compressive therapy in case of venous or mixed etiology wounds, and that it is compatible with any cleaning protocol, including the use of antimicrobial solutions. Reoxcare prepare the wound bed for other advanced wound technologies such as the application of a negative pressure therapy, the skin graft or skin substitute, the use of platelet-rich plasma, or other technologies directed to other phases of the wound healing process. Here you have different papers, also different works that we have presented to the main national and international meetings, and all this information you have, and you can download all this information in our webpage, that is reoxcare.com. And now we are going to visit the wound care units, and I'd like to show you briefly the results from our clinical trials in wounds from different etiologies. This was our first clinical trial that we performed in collaboration with UNAUP Society at different locations in Spain with chronic wound units. In this trial, we included mainly chronic wounds in aged patients with several months of evolution and important comorbidities also. And we could observe that Reoxcare produced a significant decrease in RESVET score, especially in the first 4 weeks of treatment in the inflammatory phase. We have good results both in chronic and acute wounds in these patients. Most of these patients presented important comorbidities, and that's why we recommend the use of Reoxcare in chronic wounds, but also in acute wounds in patients that present chronic disease, that present important comorbidities. We are going to avoid the wound chronification if we start early with the treatment of Reoxcare in this type of patients. And here we have some of the wounds included in the study. In this case, we have a diabetic patient that previously treated with a negative pressure therapy without results in this case. As you can see here, we have a clean wound bed. We are going to directly promote the granulation tissue formation. Here we have a calciphylactic wound that is very inflammatory etiology, very inflammatory, very painful wound. We observe how Reoxcare helped to clean this wound bed, and especially this patient referred a significant pain relief. And we have several wounds of traumatic origin. There were traumatic at the beginning, but finally turned to chronic wounds due to the patient's comorbidities. And here you can see how Reoxcare prepared the wound bed, eliminates the non-viable tissue, and promote the wound healing evolution. We have performed also a clinical trial in diabetic foot ulcers here in the main hospital here in our area in Vizcaya, Hospital of Cruces. We included diabetic foot ulcers with a neuroischemic component. Many of them come from the amputation surgery. Here we have some samples, some of the wounds treated with Reoxcare in these patients. And I want to underline that especially Reoxcare in these patients is very important because diabetic patients, because of the disease, because the diabetes, are going to produce more free radicals, are going to have a decrease in their physiological antioxidant defenses, and are patients that are always submitted to a chronic inflammation in these tissues. So Reoxcare is especially indicated in diabetic patients, in wounds of diabetic patients in the diabetic foot ulcers. Here we can see a wound that had the tendon and the bone exposed. We can use, if we have this subcutaneous tissue exposed, and we are going to maintain the adequate irritation of this tissue and to promote the formation of granulation tissue in this type of subcutaneous tissue, and to cover all this tissue with granulation tissue. In this case, a patient with a strong fibrinous tissue, and with Reoxcare, we obtain in each change a softer fibrinous tissue, and that results in finally in an elimination and a preparation of the wound bed, and finally a closure in the closure of these wounds. Another case of this type of wounds in these patients, and how we promote this closure in these extremely difficult patients. And this is another example of this type of wounds that were included in this clinical trial. Okay, we have finished also another study, post-marketing study in pressure ulcers, and we performed this study in a special hospital here in Vizcaya, in Hospital de Gorliz. That this hospital is that normally have patients with special conditions. All of them promote the formation of pressure ulcers. So we included these pressure ulcers of grade 2, 3, and 4, and this is some of the wounds that we included in the study with the subcutaneous tissue exposed. Here we can see how we increase the formation of granulation tissue formation, how we help to eliminate this non-viable tissue that was in this type of patients. Here we can see very, very easily how we improve granulation tissue formation and the elimination of this tissue. In this case, in this patient, this wound had 7 months in evolution, and how this granulation tissue, this tissue in the wound bed, how dramatically changed with the use of Reoxcare. And these special wounds in a special location in the head of the patient. In this case, here the fibrinous tissue at this location is very consistent, and with Reoxcare we obtain a soften of this type of fibrinous tissue or sluggy tissue, and finally we obtain a very, very prepared wound bed, and that promote the wound closure. And we are now preparing a paper also in this clinical trial in chronic ulcers from different etiologies that we have performed in Andalusia, in different centers of Andalusia. With, as I have said, in non-healing ulcers from different etiologies, mainly venous leg ulcers. And again, we obtain a significant decrease in the Risvet score that indicate the improvements in the wound healing process. Here, at week 12, we obtain a wound healing rate of 80%. That in this type of chronic wounds is very important and very relevant. We again obtain a decrease in the pain along the treatment with Reoxcare that we assessed by visual analog scale in the patients, and we also decrease the presence of biofilm in the wounds that we evaluated by following clinical observation through the algorithms by Metcalfe. And this is 3 wounds that we included in the clinical trial, that's like these pressure ulcers, and that had several months of evolution, and we achieved we activate the wound in these patients. Again, another calciphylactic wound, and how we decrease the inflammation in the wound and prepare the wound's bed to obtain the closure. And also in these venous leg ulcers with 6 months of evolution, and how here we decrease the inflammatory signs in the wound, and how finally prepare the conditions for the appropriate wound healing process. We are now performing the Reox trial, and in this case is a trial that is randomized. We have a control group and a group of treatment of Reoxcare. We are now just recruiting patients. We have recruited 15 patients in different health centers in Andalusia. And here, just the last slide to underline that, among other factors, oxidative stress control is also a key factor to achieve the improvement in the wound healing. So thank you very much for attending to this seminar, and I will be delighted to answer all your questions.